shared, and I was like, all right, we've checked all the boxes. I'm okay to go. Director Hattie, are you ready?
We're ready.
Good
Action.
Oh, thank you for my cue. Good evening, everyone. My name is Jerome Evans, and I'm one of the co-chairs of the Public Health Advisory Committee. Before we begin, I'd like to note that this meeting includes the remote participation of members as authorized under Minnesota Statute Section 13D.021 due to the declared local health pandemic. I will now call this meeting to order and ask Hattie, our clerk, to call the roll so that we may verify the presence of a quorum.
Terry Ann Jones. Mary Pike.
Present.
Oh, good. You made it, Mary.
Thanks.
Kosar Mohammed. Lisa Nakotra.
Present.
Anna Arkin.
Present.
Alicia Jackson.
Present.
Jerome Evans.
Present.
Andrew Crook. No Andrew. Britt Culp.
Present.
Swad Salad.
Wad was not going to be able to attend tonight.
Thank you. Meredith Martinez.
Present.
Twee Kim.
Present.
Babette Apland.
Babette is also not able to attend tonight.
Erin Hurley.
Present.
Angela Punjabi.
Present.
Terry Ann Jones. Kosar Mohammed. Okay, well, we have 10 members tonight, so we have quorum.
Awesome. Thank you very much, Hattie. Turning now to the minutes and the agenda. As a reminder, we do vote on these all at once. Were there any questions or discussion on the minutes from last month? Seeing none. Britt, would you make a motion to accept the minutes and approve the agenda for this month?
Sure thing. Motion to accept the minutes and approve the agenda for this month.
Awesome. And Lisa Nakotra, would you mind seconding?
Second the motion, yes.
Wow, really fantastic motion and second. Thank you very much. Patty, will you do your thing?
Mary Pike.
I vote yes to accept.
Kosar, if you joined us yet. Oh,
Not yet.
Lisa Nakotra.
Yes, accept.
Anna Arkin.
Yes.
Alicia Jackson.
Yes.
Jerome Evans.
Yes.
Andrew, are you with us yet? See him. Britt Culp.
Yes.
Swat. Oh, she's not here tonight. Meredith Martinez.
Yes.
Twee Kim.
Yes.
Erin Hurley.
Yes.
Angela Punjabi.
Yes.
Okay, so moved. And carried and approved.
Moved and approved. That's what I like to hear. All right, we are going to move into our presentation. But just before I introduce our presenter, who I'm very excited about, I'm going to let you know, as you received by email from Margaret today, after the presentation, we are going to go around. We're going to ask 3 questions, probably one at a time. Question 1, what was your gut level reaction to this presentation? In 1 or 2 words, preferably. Question 2, what new insight did you get from this presentation? And then finally, does this report resonate with PHAC's priorities? Now, I'm really excited to introduce Dr. Nathan Chobolo. Hey there, how you doing? Yeah. Okay, you are gonna unmute and I'm gonna read the bio. Once again, sir, I am reading your bio. Dr. Nathan Chobolo is medical director for the state of Minnesota's Medicaid and Minnesota Care programs, senior equity advisor to the commissioner of the Minnesota Department of Health, and a general pediatrician and an internal health medicine hospitalist with Park Nicollet Health Services and Health Partners. And I may have missed some items on your resume, and I apologize for that. Welcome.
Thank you, Jerome. Thanks,
Yes.
everyone, for having me here. Happy to share some of our work. I'll pull up my slides.
I believe we did receive also a copy of the report by email from Margaret ahead of time.
So, all right. Let's see. Can you see the slides?
Yes.
Just move this over here. All right. So as Jerome said, I'm the Medicaid medical director for DHS, the Department of Human Services. Been serving in that role since January of 2020, which I always say is a great time to start in state government right before a pandemic. But learned a lot, and happy to be here to share some of the work and some of the reasons I came to the role with the state. Before we enter this conversation, really trying to grow in our recognition of past trauma and abuse from the perspective of the state of Minnesota, the Department of Human Services, really recognizing that trauma, medical abuse, and discrimination have happened to our Black, Native, and American Indian communities, other communities of color, those who live with disabilities or identify as LGBTQ+, and how that's led to distrust in medicine and social service providers and contributed to the inequities we're going to talk about here today. And so the work of equity and anti-racism really requiring that we be actively committed to rebuilding that trust, really considering the many legacies of violence, displacement, migration, and settlement that bring us together today. I also find it's helpful to work from some shared definitions. And so we'll be talking about things like the impacts of racism and anti-racism. And so the definition I use of racism is that coined by Dr. Camara Jones, who is a physician, a PhD epidemiologist, and former president of the American Public Health Association. And she's been talking about the impact of racism on health and public health for over 20 years now. And she defines racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. And therefore, anti-racism is defined by Dr. Karen McKinney, who works at DHS here, and her colleague from Bethel University, Jesse Essenberg, is a personal and collective identity which embraces the intentional dismantling of our racialized society and proactively builds racial peace. And then since we're talking about policy, good to think about what anti-racist policy looks like. And so as Dr. Ewan Max Kendi has coined it, any measure that produces or sustains racial equity between racial groups. And then where does equity fit into this? Well, health equity is defined as the absence of unfair and avoidable or remediable differences in health among population groups, defined socially, economically, demographically, or geographically, as defined by the World Health Organization. I think it's important to remember that focusing on racial equity is not a zero-sum tactic. It really actually improves policies and programs for all, and really is in alignment with our stated goals, as we see in Governor Tim Walz's very first executive order on establishing the One Minnesota Council on Diversity, Inclusion, and Equity, which stated that all Minnesotans should be provided the opportunity to lead healthy, fulfilled lives. However, the quotes at the beginning of the report recenter us in the reality that we are far from our stated goals and ideals. Dr. Martin Luther King Jr. noted that of all the forms of inequality and justice in health is the most shocking and the most inhuman. While Dr. Evelyn Hammonds, a historian at Harvard, has noted there's never been any period in American history where the health of Blacks was equal to that of whites, disparity is built into the system. And that is how we want to set the frame for a report because this is, of course, not news to many in our communities in Minnesota. Dr. Samuel Myers from the University of Minnesota coined the term Minnesota paradox to describe how Minnesota can have one of the highest qualities of life for white Minnesotans, as depicted by this famous Time cover of Governor Wendell Anderson. While African Americans are worse off in Minnesota than they are virtually every other state in the nation. And as we look at high rankings for education and health, we often see different rankings when we look by communities along lines of race in Minnesota. So this report makes the case that for Black Minnesotans in particular, this inequity stems from a system that has been built over hundreds of years, in large part by policies that, while they often didn't explicitly use the words race or target Black or American Indian or other marginalized groups, when they were carried out and put into practice were explicitly racist. For example, the redlining of neighborhoods. And so for Black Minnesotans, the consistent denial to the same opportunity for housing, education, nutrition, healthy neighborhoods, and justice under the law has contributed to the disparities we see. And so when examining how we got here, it's really important to internalize the distinction between an inequity, which is an instance of injustice or unfairness, and a disparity, which is the noticeable and usually significant difference or dissimilarity. So structural racism is therefore the inequity that leads to racial disparities. Another way of putting that is it's not race driving these disparities, but structural racism. And given the inequities that Black Minnesotans face, it's not so surprising that we see worse health outcomes for both adults and children, as depicted on the left. And on the right in the report, we note that US-born Black communities are predominantly descended from individuals subjected to chattel slavery, Jim Crow segregation, mass incarceration, and police violence, disadvantaged neighborhoods, less wealth and less opportunity, which has all been shown to lead to chronic intergenerational stress. And these features of structural racism have contributed to the racial health disparities we see today. And so the report looks to build off of great work already done around equity in DHS more broadly. Much of it started by our community's leadership council, which emphasizes our commitment to advancing equity, reducing disparities in DHS program outcomes, and improving access to human services for all communities experiencing inequities. And its foundation was the Health in All Policies approach, with the goal of having a human-centered design framework that considers health beyond the absence of disease, but to a complete state of physical, mental, and social well-being. And so this really compels DHS staff that communities experiencing inequities be consulted when programs are designed, implemented, and evaluated. And one step that we've been doing within Minnesota Medicaid has been trying to operationalize a racial equity assessment when we look at policies and budgets, and really re-examining, how we engage community as we put forth policy and budget proposals. But to really utilize racial equity assessments, to really be led by the community, we had to have a different understanding of how investments in and cuts to our programs and policies impacted communities differently in Minnesota. And so we worked with Lynn Blewett in her shop at Shadak to look at how Minnesotans get access to healthcare and how that is different based off of your racial identity. And so on the left there, you see in 2018, roughly 60% of Minnesotans got healthcare access through their employer-sponsored insurance, with 14% being on our Medicaid or Minnesota Care programs. However, if we look at communities by race, we see a different picture. And so in 2019, 41.5% of Black Minnesotans got their coverage through Medicaid or Minnesota Care, 39% of American Indian and Alaska Native Minnesotans, 29.5% of Hispanic or Latino Minnesotans, 20% of Asian Minnesotans, and 9% of white Minnesotans. And so really, if we're trying to address health equity and try to address racial equity, Medicaid is a really crucial part. And it's even more notable for children in Minnesota. And so when you look at children 18 and younger, 64% of our Black Minnesotan children get their coverage through Medicaid or CHIP, 54% of American Indian and Alaska Native, 52% of Hispanic and Latino children, 31% of Asian children, and 17% of white children. So we note that Minnesota has some of the worst racial inequities, which lead to the worst racial health disparities. Black Minnesotans are disproportionately covered by Minnesota Medicaid, and therefore Minnesota Medicaid must focus on racial equity. However, we note that MDH put out a report in 2019 that talked about culturally relevant care, and they highlighted how just stopping at Black Minnesotan doesn't tell the whole story. The data often masks disparities impacting US-born Black community members in particular. And so we did look at our data within the Medicaid program amongst enrollees by not only race and ethnicity, but country of birth. And what we did see was some disparities that were further amplified based off of country of birth. And so what you're looking at here is different conditions and the prevalence of different conditions. And dark gray boxes are the boxes where that condition had the highest prevalence amongst groups. And then light gray is either the second or third highest prevalence. And what we see quite clearly is when we looked at African Americans, even though the average age of enrollees that we looked at here was the same, roughly 35, US-born Black or African Americans had higher rates in every adverse outcome than those who immigrated to the US, in particular between the groups' rates of things like asthma, heart disease, and depression were 3 times higher for US-born African Americans. And overall, they had some of the highest rates of all conditions in the group. And so, given the distinct current and historical contexts that have contributed to the health of Black communities in the US, and in order to focus on specific community strengths and the opportunities to build racial equity from their perspective, we chose to focus this report on US-born Black communities. As we said, this report aims to continue the evolution of how policy is designed, proposed, and considered by intentionally striving for greater community co-creation. And so with this report, we really aim to land on the involve area of the International Association of Public Participation's spectrum. And so as you can see here, our goal there is to work directly with the public throughout the process to ensure the public concerns and aspirations are consistently understood and considered, while coming back to community and making sure that our concerns and aspirations are directly reflected in either the report or alternatives developed, and provide feedback on how public input influenced this decision. And then we also note in the report that neither Black immigrant nor US-born Black communities are monolithic. The experiences of Black Minnesotans can and do vary by their geography, income, sexual orientation, and gender identity, and the other communities and beliefs they identify with. However, the impact of structural racism is felt by all to varying degrees, and so this is what guided the focus of this report. So to start to meet that at the onset, we had conversations with Black Minnesota community leaders, members of the Black Minnesota community, and those who are working to improve racial health equity in healthcare about the scope and goals of the report. And we framed it through 4 levers that you see there on the left, and we'll go through in just a bit here, but eligibility, enrollment, access, quality, and early opportunities. And so from there, we took that input and feedback and had discussions with our staff internally at DHS on who are working in those areas of policy identified by those conversations with community, and really tried to narrow down to what could be some calls to action that we could really work on and continue to build for. And those conversations then informed the draft calls to action that we shared during 2 public community conversations that were held last fall. And you can see from the box there the lived experiences that different individuals brought to those community conversations. And so the report calls to action, again, incorporate all of this feedback and recommendations into the report. So we'll talk a little bit about these levers and what are some of the pieces that we found looking both in talking to community, but also looking at the literature about these levers and how they impact racial equity in Medicaid. First is eligibility enrollment. So who is eligible for Medicaid? What is the process for enrollment, for re-enrollment? How does someone get and keep their Medicaid insurance in the first place? And so I actually need to update this slide because just late last week, the Department of Health released updated statistics on the uninsured, but this is from 2019, where we see that amongst folks who are uninsured, almost half were potentially eligible for public insurance, so Medicaid or Minnesota Care. And so we know that having Medicaid coverage improves access to screening and preventive care, permits earlier diagnosis of chronic conditions, and improves mental health outcomes. But we know that folks who go on and off Medicaid, that's not distributed equally. And so we cited two different surveys, one that looked at income volatility. And so your income from week to week or month to month goes up and down, and that impacts your eligibility, because if you make a certain amount of money, then you'll be asked to verify that and potentially lose your Medicaid coverage or have to be switched to more costly coverage. And so we see that income volatility impacts households differently along lines of race. In this study, they found that 45% of Hispanic households, 38% of Black households, and 32% of white households experienced income volatility throughout the year. And then there's also this idea of churn, and that is that folks go on and off Medicaid, even though they're eligible, whether it's things like income volatility or just administrative barriers in getting notified about having to re-enroll or having to fill out applications. And they found that Black Medicaid enrollees were more likely than white enrollees to go off Medicaid for more than 6 months. And that if you were off Medicaid for more than 6 months, you were less likely to have a regular source of care, more likely to forego health care for financial reasons, and more likely to report problems paying medical bills. And this really echoed with community when we talked to them. There was a lot of examples of how the process for enrolling and finding out if you're eligible can be confusing or complicated. How even if you enter into that process, that communication on your status is often poor, and not knowing where your application is impacted whether or not you could go get care. And then a real desire to understand how we can keep people enrolled who are eligible, and that not letting red tape be the reason that folks lose coverage and lose access to health care. And we did hear about some solutions. So former work back in 2016, interviewing community members who told us that working with navigators really helped and was really valuable, particularly for people who didn't have a computer or internet access at home. And they found that participants who received help applying for coverage through MNsure navigators reported a far better experience and fewer challenges in getting started than those who did not. The second lever is access. And so you have your insurance card, but can you actually access the care you need? Do you have geographic access or physical access? Do you have transportation to a provider? Do you have providers that have your shared lived experience or shared culture and you feel safe in getting care there? Do you have access to specialty care like behavioral health, mental health, or dentistry? And we know from data stemming back now well over a decade that folks served by our programs have had barriers to access. As you see here, 55% reported just general access barriers and 49% reporting feeling barriers due to discrimination. So that was described as unfair treatment due to gender, ability to pay, enrollment in Medicaid, or race, ethnicity, or nationality. And we've tried to further understand what some of those barriers might be by including different questions in our patient satisfaction surveys. And so these are the surveys that go out to our Medicaid enrollees every year. And this is from 2021, where we added a question about, in the last 6 months, how often were you informed you showed up too late to an appointment to still be seen? And this is to kind of get at if folks are, overcoming some of the, maybe those transportation barriers, and they're overcoming, childcare barriers. They find someone to take care of their children. They get on 2 buses and they get to a clinic and they're 5 minutes late, and then they're told they're not able to be seen. Well, that's a policy barrier that we can hopefully try to address. And we did find a difference there. With a statistically significantly, Black respondents were statistically significantly more likely to be told they showed up too late to appointment to still be seen. So 95% of white respondents said they were never told they were too late to be seen versus 84% of Black respondents. And then looking at access through the lens of our partners. And so 80% of folks enrolled in our public health care programs are served by managed care organizations, your health plans. And so they really have a role to play in really ensuring that our enrollees get access that they need. And when we talked to community, they put a priority on access to culturally relevant care. And they note that there's a significant amount of literature that demonstrates, that both Black adults and children are the recipients of unequal care. One of the things that can impact that is if there is a shared race and shared lived experience of your provider. And however, in Minnesota, we have a mismatch in the number of Black physicians and Black PAs versus Black individuals. And so making sure that folks who do practice are practicing cultural humility in their care and respecting the role of culture. And we often heard from community that culture is missing. And that was described as the fabric that links an individual to their community through shared beliefs, knowledge, practices, and protections. And that loss of culture in the healing space contributed to illness by separating an individual from one of their shared strengths. You can see some of the quotes there from participants in our community conversations about not feeling heard or not feeling treated the same as other patients. And so there's a lot of ideas that they also provided as ways that we could look at things like our data to identify the number of providers that are practicing culturally relevant care or who identify by race or ethnicity with the communities that they serve, and think about solutions that way. The third lever is quality. So an enrollee has their insurance card. They are actually able to get in front of a doctor or a nurse practitioner, a therapist. Are they getting the same level of care as other Minnesotans? Are they getting the same level of care as other Medicaid members? And are the measures we are using to define quality, are they consistent with what community would define as quality care? And so what you're looking at here is a report that's been done for over a decade now. Minnesota Community Measurements looks at our data and looks at different quality metrics to see how our enrollees who are served by managed care organizations and on Medicaid do versus Minnesotans who are served by managed care organizations that aren't on Medicaid. And what you see here is just one example of a pattern we see across the board, and that is the yellow bar there is those who get their insurance through private insurers versus the blue or green bar there, those who get insurance through our public insurers. And there's been a consistent gap, for over a decade between Minnesota enrollees on our Medicaid programs and colon cancer screening rates and those on private plans. However, there is a gap within a gap as well. And so we see within our enrollees that Black and Indigenous enrollees in particular have consistently had even lower quality metric results than the other enrollees. And so again, identifying the impact of structural racism and how that shows up in multiple places. Minnesota Community Measurement also over the last 2 years now has started to look at difference between English speaking and country of origin within different racial and ethnicity groups. And what they found in the report last year is that Black patients in Minnesota who preferred language as English had significantly lower rates of optimal diabetes care, optimal vascular care, and depression remission at 6 months. And we also see the same pattern for those who are born in the U.S. versus those born outside the U.S. And so this, again, kind of touches on what has actually been described in literature as a healthy immigrant effect. It's seen in the U.S., it's been seen in Canada, it's been seen in Europe, where there is thought to be some selection bias where folks who are healthier end up making the trek over here. But there's also a real impact of generations of structural inequity and structural racism. And that is what we believe is being captured here. And again, one of the reasons we focused on the US-born community in this report. And so when we think about what community shared about quality is that we need to do a better job proactively identifying data, that the way we collect data is not moving at the same speed as how diversity is increasing. And really thinking about how are ways we could use that data, again, to work with healthcare systems and insurance companies to train and identify employees who need to be or who are engaging with our communities of color. How do we build an accountability and measurement to our disparities? And then the fourth lever is what I've termed early opportunities. And so we talked about how Medicaid disproportionately covers children of color in Minnesota. It also disproportionately covers pregnant persons and birthing persons. And so we see that Medicaid or medical assistance covers 40% of births in Minnesota. When you look amongst Black birthing persons, 8 out of 10 in Minnesota are insured by our Medicaid or Minnesota Care programs. And then again, we just similarly highlight that our children are also predominantly covered. And so we know that if we are going to really move the needle on racial equity over generations, we need to start early because so many of the disparities and gaps we see do start early. And so really thinking explicitly on how do we build racial equity into eligibility, enrollment, access, and quality for our mothers and fathers and our youngest Minnesotans is critical. And a failure to address racial equity in maternal and early childhood policy is going to set the health and opportunities presented to Black children on a different trajectory and really make our state's commitment to equity that much more difficult to achieve. So again, to recap, we use those levers to frame the opportunity for action, provided that to our community leaders initially, got their input, talked to our staff, came back and talked to community and conversation last fall, and incorporated all of that into our calls to action. And so you can see on the box there that that was the results from one of the surveys from our community conversations about which calls to action they were most excited about. And it really was proposals around continuous enrollment or addressing eligibility and enrollment. And so those are all these are the 3 different reports calls to action, and we'll kind of go through them a little bit more here. But we do want to note that none of these calls to action seek to create Medicaid-funded services that are racially exclusive. Really, what we're looking to do is recognize the long overdue need to ensure policies, programs, and the administration of each are done with awareness and action towards racial equity. And when you look through the report, you saw that we also tried to frame it around why does the problem exist and what has Medicaid done to address it, and then provide the calls to action to continue to improve. And when we reflected on our fall community conversations, we came away with a clear sense of urgency from the community and DHS staff alike to address this, that widespread agreement that we could be doing much more around racial health disparities, and a lot of ideas were brought forward to have further conversation around solutions. And then really acknowledging that there was a shared concern that, in the past, DHS and other state agencies have come and asked some of these same questions. And, it's been a flash in the pan, and that this might be just another example of that. So, to really try to address that and to really hold ourselves more accountable, we did include these accountability call out boxes after each call to action in the report. And, Medicaid policy is really complex because it is a federal program, and there's federal rules and regulations that get set by the US Congress and the US federal agencies. It's a state program, so there's pieces of it that get set by the state legislature and then our state DHS agency. And then it's really carried out in cooperation with many different partners, right? And so what we really tried to do is land on things that we as DHS in that scheme can really be held accountable to, recognizing that there's many different ways to get to racial equity. It's not, which tool we're using, but it's the outcome that matters. And so to put forward outcomes that we thought would help us reflect the calls to action and the work here. So our first call to action is around simplifying and supporting enrollment and renewal. And so we provided some examples of what Minnesota DHS has done, support for navigators, particularly during the pandemic, where the legislature did change some incentive monies that the navigators couldn't get because of some of the broad policy changes in response to the pandemic, to grant funds so that they could continue to operate and serve Minnesotans. We're continuing to work on how do we improve accessibility to Medicaid application in line with other DHS programs. And so if you hadn't heard, there's a new portal called Minnesota Benefits, and that is a way to sign up for a number of different DHS supports and services. And so we're working to try to get Medicaid to be one of those. So essentially you could really have a one-stop shop for all of your DHS programs, and having Medicaid part of that would be really critical. And then maintaining enrollment during incarceration. And so, we note that in 2015, statistics showed that Black Minnesotans were incarcerated 9 times more than white Minnesotans, and that there's research that show that this disparity in incarceration contributes to racial health disparities. One of those reasons is that there's been policies that terminate people's Medicaid coverage upon incarceration. This would require them to reapply for Medicaid when they are about to be released. But during COVID-19, DHS put in place a procedure to ensure that Medicaid enrollees remain enrolled in Medicaid without interruption. And under this new policy and procedure, they remain enrolled during incarceration and then have full coverage restored upon release. And so we're currently working to make that permanent in Medicaid eligibility systems. However, there's much more we can do. And so based on that kind of understanding of this lever and our conversations with community and DHS staff, our first call to action to improve racial equity in eligibility, enrollment, and renewal is pursuing continuous eligibility policies. These are also sometimes referred to as continuous enrollment policies. And this allows that once someone is signed up and deemed eligible, that they remain eligible regardless of any changes in circumstances for up to 12 months at a time. And so this is actually available for children on Medicaid, and 32 states already offer this for their children on Medicaid. So Minnesota is behind on that. And so our first recommendation is that Minnesota catches up and implements that as soon as possible. Additionally, though, we feel like DHS can go a step further and put forth what we call 1115 Medicaid demonstration waiver, which is basically a way to ask the federal government to allow us to try something. And we believe that we can make a case to try 72 months of continuous eligibility for children on Medicaid up to age 6. So 6 years essentially of continuous eligibility. Once a child under 6 is deemed eligible, they will remain enrolled until age 6 unless they choose to come off. And then 24-month continuous eligibility for everyone else. So basically everyone else age 6 and older, once they get enrolled and are deemed eligible, they get at least 2 years of coverage before they have to re-verify. Really citing 2 things, and we actually borrowed this from Oregon's 1115 Medicaid waiver, where they've actually asked for these 2 things specifically. And in that they cite, like we talked a little bit about here, the importance of access to health care resources and other resources and supports in early childhood. And so really making a case that in those first critical years of life, we want all our children to have the best opportunity. And so they should all be kind of universally covered essentially. And then we've basically had continuous eligibility for more than 24 months during the COVID pandemic. We've had continuous eligibility in place since the CARES Act was passed in the spring of last year. And that really saves on administrative costs and keeps people connected to care. And so again, this would be open to everyone, but we know from the data that likely would be disproportionately beneficial to our US-born Black Minnesotans. Second was supporting navigators and helping them simplify the enrollment and renewal process. And so putting forth funds to continue to support the work that navigators do, and actually thinking about a plan that would ensure eligible Black Minnesotans gain or maintain Medicaid coverage, particularly as we come out of the public health emergency and we're going to have to go back to some normal processes. How do we make sure that we don't see a disproportionate impact in who loses access to the healthcare coverage because of administrative barriers? Our second call to action was around access to culturally relevant care. And so a couple examples of things we have done, we've attempted to foster more culturally relevant care via non-licensed paraprofessionals who are more likely to reflect the diversity of their patients. And so things like doulas and community health workers. And so we've also tried to launch several grant programs. One of them cited in the report was our Integrated Care for High-Risk Pregnancies program, which works specifically with American Indian and African American mothers and fathers and communities to build up supports around pregnancy that are culturally responsive. And so those are some examples of things that we've done, but we know that we need to do more, and that providing culturally responsive care includes things like acknowledging historical trauma and working on things like access to resources, education, as well as healthcare. So to address generations of structural inequity is really going to require sustained intention, which is why our second call to action, the first part of it is investing in an internal structure that has a specific focus on US-born Black Minnesotans. And so this dedicated internal structure could provide a direct connection to US-born Black Medicaid enrollees, community-based organizations, and other institutions to inform and co-create policies and programs that really try to elevate strengths and address inequities. It could work to make sure that our efforts at DHS, as well as other state agencies like the Department of Health, are really leveraging all available funding sources to close gaps, engaging physicians and other providers on their own cultural humility and training to make sure that they're providing culturally appropriate care, and even looking at certain benefits and really interrogating whether they're reaching communities the same way. And so one thing we talk about is our recent housing stabilization services benefit, and maybe taking a look at, is the community aware of it? Is it being utilized and accessed by the US-born Black community the same? And so there's some precedent for this approach. In April of 2020, DHS launched the African American Child Wellbeing Unit to help address structural racism in the child welfare system by providing oversight and assistance to county agencies, as well as grants to community-based organizations working with African American families. And so envisioning a similar structure within Medicaid. And then the second was continuing to prioritize standardization and disaggregation of race, ethnicity, and language data. Really recognizing that it's an incomplete and imperfect proxy for culture, but that data can really serve as an important initial signal and then inform conversation and collaboration with communities. And really using that, so many of the solutions that communities brought forth as ideas of, putting accountability on our managed care organizations or measuring quality metrics by more disaggregated data, requires that be reliable and standardized so that we're coming to the correct conclusions and not thinking that we're actually helping address the problem when we might be missing it altogether. The third call to action is around engaging communities and families Medicaid serves. And so this is seen in all our discussions with community members and DHS staff. There was a shared desire for more meaningful engagement and co-creation, kind of acknowledgement that top-down policy solutions have been tried, and yet disparities continue to grow. And so really continuing to improve how we find solutions in consultation and partnership with communities. And some examples of what we've done is there's an Office of Community Engagement that again does try to work with communities, but really usually not through a culturally specific lens, apart from some specific conversations that happened in response to George Floyd's murder and police violence in 2020 and 2021. And so community members shared a need for that community consultation in general, but really for culturally specific consultation with communities. And that needs to be ongoing, longitudinal, not just coming for saying we want to get better diabetes control and diabetes rates, so let's just talk about diabetes, but really kind of talking in an ongoing manner that allows folks to really kind of share their true lived experience and provide solutions on a number of things, and really continue to look for where can power be shared between the state agency and communities who are engaging us. And so our third call to action is funding those community conversations, those longitudinal community conversations, and really finding ways to embed it into our routine policy, budget, and administrative activities. And community members noted repeatedly that the COVID-19 pandemic has clearly demonstrated the impact of a fractured trust between state agencies and the US-born Black community. And so this requires relationships be built or rebuilt over years, and really gives the community the opportunity, as one member stated, to start a journey of trusting larger agencies that provide resources and services. And so we talked about these call to action boxes and where we are trying to build in accountability into the report. And so you can see here for each of the calls to action, there's an outcome. So for the first one, looking at enrollment and coverage renewals, our outcome is that we'd see a minimal disparity in the percent of US-born Black Minnesotans who maintain coverage at the end of the federal public health emergency compared to average Medicaid enrollees. Accountability around access to culturally relevant care as we see an increase in number of and utilization of culturally specific providers on our Medicaid programs. And then the last one for engagement is that there is sufficient funding for longitudinal authentic community conversations. So we wrap up the report by kind of reflecting on the moment we are in for change. And we looked at what was happening across the country and found some interesting similarities. And so on his first full day in office, President Biden issued an executive order which established the Presidential COVID-19 Health Equity Task Force. And they met with hundreds of subject matter experts. They had extensive literature reviews of what is being done to address health equity. They had 8 4-hour-long public meetings with comment, and came forth with a report last fall that had 55 recommendations and 5 overarching priorities that you can see here. And we found it quite notable that the result of all that really intentional, resource-intensive work was very similar to our conversations and the work we've been doing with the US-born Black community over the last year, as far as investing in community-led solutions, looking at a data ecosystem that promotes equity, increase accountability, investing in representative healthcare workforce, and having an internal infrastructure that is focused on health equity. And so I think this, to us, lended credence to our approach and how, when we focus on one community, that the benefits to that aren't only felt or experienced by that community, that in fact it will help the system improve for all and improve for other marginalized communities as well. That said, the calls to action that we detailed and justified really or serve as a model for us to continue working with other communities in a similar process. And so we hope to come back here and talk about future reports that we will be doing, focusing on the American Indian and Native or Indigenous Minnesotans, Hispanic, Latinx, Asian Pacific Islander. New Minnesotans are our term for our immigrant and refugee populations. Minnesotans who identify as LGBTQ+ or live with disabilities, are unhoused or incarcerated. And so really the hope is this momentum leads to some immediate changes that come out of the report. And the changes you see here are all in the current House Health and Human Services Omnibus Bill right now. So we did get the simplified enrollment and renewal processes, as well as the continuous coverage for children 12 months at a time, funding for community engagement, making access to doulas easier, as well as support for navigators. That's all included in the Health and Human Services Omnibus Bill on the House side right now. And so there are ways that we can kind of talk to our legislators, continue to talk to our senators, Minnesota House and House Representatives and Senators and the governor's office, and say that these are priorities that are reflected again in this report. And so we've had, again, part of our desire to have meet that involve on the International Association of Public Participation spectrum is to come back to community and say, here is, what your help and input in the report resulted in. And we've had one community conversation last week. We have another one next month in a couple of weeks where we're sharing the report. We're continuing to hear, what resonates. What did we miss? What are people most excited about? And the hope is to then, coordinate around those areas from the report that people are most excited about and launch some action groups that really help, again, inform how we move this through the process of becoming continuing to be a priority at the agency, make it become a reality. And then we've also started planning for our next report, which we hope to work with the American Indian community on as well. And so the report wrapped up with kind of reflection on all this work is not groundbreaking, really. Folks have been talking about the structural the impact of structural racism on health for over 100 years. W.B. Du Bois was talking about it back in the early 1900s. And so we reflected on, what we hope is different is that there's urgency that sustains us this time. And so we leave with a quote from W.E.B. Du Bois that now is the accepted time, not tomorrow, not some more convenient season. It's today that our best work can be done and not some future day or future year. So, big thanks. This was I'm here representing a team effort, both within the reports, within all the community members and organizations that contributed, as well as the folks who helped the community conversations come to life. I want to thank you for your time this evening, listening. Really, really interested and excited to hear folks' reactions to it. We do have this upcoming community conversation if you want to hear me go through that report again, but then have a chance to talk and share and hear from others. So please do register there. If you're interested in joining any of our action teams, we have an email set up, brewmedicaid.dhs@state.mn.us. And we'd love to hear from you. So thanks again for your time, and I look forward to the conversation.
Well, I mean, yeah, thank you very much. I know, one, how difficult it is to speak for an hour. That was very impressive. Thank you. We're also after hours. I believe I saw in an email chain, so I appreciate you taking some extra time and really dropping some knowledge on the committee that I think we've all been asking for a while. I'm looking for this type of data that we can possibly leverage to set direction as we identify priorities that we would like to move forward on.
And the data definitely confirms a lot of our speculation and suspicions and things that we've noticed anecdotally, but now, thank you to Dr. Chobolo, there is data to back it up.
Indeed. Okay, one small point of order. I do want to, I guess Aaron Hurley would like to have the first comment, or second comment now, Britt. If you don't mind raising your hand in the chat, I'll call on you just as we get through. There was a slide, Ethan, that said 20% of people eligible for employer-sponsored insurance don't take it. There was some. Is there any additional insight into that slide that you are able to provide?
So in general, the reason people don't take employer-sponsored insurance because it's not affordable, right? And so they don't want to. They're just going to kind of roll the dice that they don't get sick or their loved ones don't get sick, or if they do, then they'll try to sign up then. But that's the main reason, is that even though it's offered through their employer, it's not affordable.
Yeah, and if I can, phenomenal presentation. That was very enlightening, and thank you for sharing all of that information. And your proposals are directly targeted at keeping people enrolled in Medicaid. And I guess I'm curious as to whether you've looked into, and this is, I agree with, social justice and understanding all of the background and the goals, but, at the policy making level, and when you're proposing things to legislatures, they want to see dollars and cents, and really for some people, who aren't so social justice minded, that's a way to bridge a conversation. Have you looked into how much having people enrolled in Medicaid and engaging in preventative care saves the state and the program, rather than what often happens, which is people wait until health has declined or there's an emergency, at which point care is significantly more expensive. So, your presentation was phenomenal. I was, glued to the screen the entire time. But I'm curious if you've considered including some dollars and cents presentation to the legislature.
Yeah, so there is data out there about children in particular on Medicaid grow up more likely to stay in school, less missed days from school, more likely to graduate, more likely to go to college, more likely to have a job, and more likely to pay more in taxes, right? So there's kind of long-term benefits that we know in children who are enrolled in Medicaid. We know that there's administrative costs to policies that try to churn through. So you might be familiar with, there was a discussion in Minnesota several years back around work requirements and trying to have folks demonstrate they have to work to get on. And that's just a huge administrative cost. Like, it's actually more costly to the state to verify if someone's worked and enter it into a system and things like that. And that's kind of seen similar with, like, you have a 6-month continuous enrollment versus a 12-month continuous enrollment. You have more costs every time you have to, because someone has to actually do that look and kick someone off. And so so there are kind of benefits from there. It's harder to tease out the long term, because there's so many different factors that go into so, like, for us to do a fiscal note analysis that when we present, we have to show savings in like 2 years. And so that's the difficult part. If I put a proposal up for continuous enrollment for kids, we know, and there's some really smart folks and Art Rolnick and others that who've looked at the impact of early childhood investments that say over 17, 18 years, there's a rate of return that's multitudes higher than most rates of return. But for anything that we put forward, if we're going to try to claim a fiscal benefit, we have to show it within 2 years, and that's just the kind of tricky part at the legislature. So but that's a good point, just to kind of try to find, even if it's not going to be maybe germane to this legislative session, the long-term cost might move the needle for some folks.
And if I'll stop in a minute here. But and I hate to use labels, but certainly more fiscally conservative and Republican minded people. I mean, that's always the the thing they want to talk about is how much these programs cost. They want to lower taxes at all times. They're not looking at the health of the community, and to me, I mean, a more healthy community is more economically productive. It's in the interest of the state, that type of thing. So there's arguments there for the economics of it. And I loved your presentation, and I'm not trying to critique it in any way, so please take it as a positive comment.
More commentary than question on this one, so we're going to move a little bit. Alicia, I saw your hand go up and down, and I wasn't sure if you meant to have it up or not.
I did mean to have it up.
Okay, go for it. You were first, and then Lisa, you are next.
Thank you. So I'll start by saying thank you for the presentation. You've come a long way from the 14th floor of Mayo. Long way. I know you from way back from the residency days from admin. So really, really great to see all of the amazing work that you've done. I had 2 points of questions, and the first one is around, and I know that you have a particular role and everyone has a role to play at DHS, but around the enrollment files and specifically the information and the wording and the language around offering up race and ethnicity data. I work for a health plan. I work for UCare. I'll be completely upfront about that. And we get a lot of DHS data every single month, every single year. And some of it's great and some of it's not. I know that currently the race and ethnicity information is voluntary. It's optional. It's not required. There's lots of rules around that. But when we think about the idea of becoming more aware of and wanting more data and more information on our people, does DHS have any changes that they plan to make to the enrollment forms around offering up or requiring race and ethnicity data?
Yeah, so that is one of the areas where we've improved a little over the last couple of years. Sat down and looked with our team at how we could try to improve what we currently had based off of, because some of that data we have in other DHS programs, right, like SNAP and WIC and child care assistance and other things like that, MFIP. And so we were able to improve. We had about 27% of our folks who didn't have any race or ethnicity data, and we were able to kind of impute from those other programs and get it down to roughly like only about 7 to 10%, right? And so that's one way that we've tried to do that. And then we have to work on I think our mechanisms of sharing that with partners. We have looked at the application, and you're right, there's rules that we can't require it on the application, but there are ways that you can try to improve it. The other states have tried by putting in some prompting text saying, this data is used for quality improvement, and or this data, 90% of folks fill this out, not having it that it's optional, just having it there. But if folks don't fill it out, the application doesn't go void. And then sometimes we've heard and seen that if you actually have more options, folks feel seen and they're more likely to fill it out. So like if it just says Black, or if it says Nigerian or Cameroonian or Liberian or Somalian, then maybe they're more likely to fill it out because they feel like they'll be seen, and then that data will actually go towards helping their community. So those are things that we're talking about and trying to improve. But yeah, you're right that there's a lot of work to do there.
Great. Thank you for the response. I'll yield my second question to my fellow colleagues because I know we have a lot in the bank.
Sounds good. It's going to be Lisa, Meredith, and then Angelique.
Thank you so much for that presentation. Really terrific. I learned a lot. But my question might be kind of basic here, I'm afraid. What is the eligibility criteria for enrolling in Medicaid? And we know it's a federal program, it's a state program, and how does it all tie in with being eligible for Medicaid versus MNsure? Are they the same? You sort of touched on it a little bit. I was wondering if you could just enlighten me a little bit on that. We all know Medicare is largely age-based, and one thing I learned from your thing was that people go on and off Medicaid with an alarming irregularity, and people don't go off Medicare because once you're 60-some, you stay on it. So just was wondering if you could flesh that out for me a little bit. Thank you so much.
Yeah. And thanks for that's good feedback to kind of think about when I go in with different audiences. The Medicaid program, the eligibility depends on the state. And so in our state, depending on income level and your age, so infants up to age 2, it's, I believe, at 283% of the federal poverty level, you qualify for Medicaid. But if you're an adult, it's like 133% of the poverty level. And so, if families, young families in particular, or families with children, can have higher income and be on Medicaid versus a single adult. And then there are a couple different issues, eligibility criteria with folks who live with a disability or fall into different categories. And you can actually be on Medicaid and Medicare, where Medicaid kind of picks up some of the holes that Medicare doesn't cover based off of your income eligibility. And then MNsure is the portal that how you access healthcare coverage if you don't get it through your employer-sponsored insurance. You can go and apply, and they then kind of will look at your income and say, based off of this, you are eligible for Medicaid. You're eligible for Minnesota Care, which is the kind of our state-run plan for folks who are making too much to be eligible for Medicaid, but obviously would have a hard time affording any private insurance. And so Minnesota Care tries to cover that gap. And then there's the Affordable Care Act, Subsidies, which you might have heard of, right? And so that means that you can sign up for a plan and get it through, Blue Plus or UCare or whatnot, but then the federal government pays them for some of it and you pay for a little bit. And so that helps kind of subsidize, right, your care so that you can find a plan that's affordable. And then if you don't make enough, if you make enough that you don't qualify for any of those, then you go into MNsure and you find a plan for just yourself or your family through the exchange there. So that's MNsure is kind of like the way you can access and sign up for it. And then yeah, those are the generally different levels of eligibility.
That does raise an interesting question about whether or not people know that they're eligible for the different programs or how to access. Meredith and then Angelique.
Yeah, just to echo what others have said, thank you so much for the presentation. I'm the family health manager at Hennepin County Public Health, and so was really exciting to hear you talk about the early opportunities and the policy suggestions and recommendations around maternal health care as well as early childhood systems work. And the continuous eligibility recommendations. So that was really great. My question is, well, at Hennepin County, we have some pandemic response funding that we are using to improve maternal health outcomes for Black and Indigenous birthing individuals. And part of what we're hearing at the local level among birth workers is that COVID has just kind of decimated the entire workforce. And so even though I know that those services already have a way to be billed to MHCP, what we're seeing now is just that even with this ARPA funding and then some of the policies really being put into place at the state level, they are still really struggling even just to be in the industry, in the service area. And so I guess my question is, do you have any thoughts on that? And is there anything that the state or DHS could do to help support that? Just knowing the impact of COVID has really hit, families who are working in some of those professions disproportionately.
Yeah, thanks for sharing that. That reflects a lot of my experience. One of the programs that I've worked really closely with at DHS since coming here is the Integrated Care for High-Risk Pregnancies program. And we've seen kind of that same issue with the paraprofessionals that have been working in that program. And so there are, I think, levers we have. You can even just look in some other responses for the state did with the whole program to fund NAs, right, nursing assistants, to try to help with the hospital surge capacity. And so I would love to see, and I think if we hear this coming from community as one of the solutions, I think we'd have even a better chance of a grant program that really helps support folks getting into the workforce, helps support them and how do they bill on their own, and kind of take it from there with the intent that they likely then be serving all Minnesotans, but particularly Minnesotans on Medicaid. And so grant programs and grant funding from the state would be kind of like the most immediate response. Certainly if there's other ways, I've heard for doulas that the $200 certification to be on the list for the state can sometimes be a barrier. So looking at ways to take away that as well. But yeah, I think that workforce piece and what we can do to kind of really help support that through grant funding would probably be the most immediate step. And so would be happy if there's interest in there, working with folks to put something together.
Thank you. Lisa, your hand is still up. So if you have another question, I see it's ordering them in my participants tab. So if you put it back up, then you'll be back at the bottom of the line. Angeli and then Britt.
Hello. Thank you for a great presentation. I had a couple thoughts and questions. I'm a pharmacist who now my career is in health equity as well, but I used to work in federally qualified healthcare centers, and I wanted to just echo what you said about the navigators. They are so helpful, and many of my patients were able to enroll with the help of a navigator. So I just wanted to speak to the crucial nature of that and second that. One thing I also recognized in your presentation was, so you called out the US born Black population and starting there and addressing those disparities. You also mentioned looking at some other populations. I was recently reading about a concept when addressing disparities. It's so important to start where the largest disparities are. Some people try to start where they see smaller disparities because they're like, oh, I can do that a little bit, maybe a little bit more easily, but take some smaller steps. But what we see in those cases is that what might have worked for a population that doesn't have as large of a disparity cannot be applied to a population with a larger disparity. So I really like this individual population approach that you're taking. I also have some questions about the REAL framework that you mentioned, the race, ethnicity, and language framework. And you mentioned some limitations in data. I'm wondering if you could speak more to us. We have a subcommittee called the Racism as a Public Health Care Crisis Committee, and we are wondering, we're looking to learn more about what some of the limitations in data are when it comes to identifying healthcare disparities. So that's one question I have. And then hypothetically speaking, if Medicaid and DHS had access to consumer data that could predict somebody's race, ethnicity, and language based off of their consumer-based habits, would that be something that they would leverage?
Okay, I heard several questions. So I think
Sorry,
the
I got
first
really
one
excited.
had to do with limitations of the REL model or what have you. And then the second you might have to repeat, Anjali, is a hypothetical that sounded interesting.
Yep. So so hypothetically we couldn't because of how we are by statute, federal and state stewards of data, and so we couldn't potentially link it to other outside sources. But it would be interesting. I mean, like, because to link it to the other social services, we did some, or I didn't do it. Our team who knows data and can do these techniques, but to confirm the reliability. And I think that kind of connects to your first question. Is the data is only as good. Or like the solution and the question you're trying to answer is only as good as the data, like input good, output good, right? And so if the data you're looking at, for example, our data, a couple of years ago was missing 27%. So if we looked at it and said, oh, well, this group has a disparity, but we're missing 27% of the data, like, do we really know that the disparity is true? Or to what degree? And then particularly as we disaggregate, right, and get kind of more closer to the truth, that is real important that the reliability be there. One other example from a local community is around if we don't have disaggregation, we can kind of think we're doing better. So COVID vaccination among Asian Pacific Islanders, they've led the way, basically since about May or so of last year. But CAL, the Coalition on Asian American Leaders, actually worked with the University of Minnesota to do an analysis by zip code. And doing that, they were able to actually look at different communities where they knew they were predominantly Hmong and Karen, and saw that their vaccination rates were much lower. Their deaths from COVID-19 were much higher, right? And when you look at our statewide data for Asian Pacific Islanders, the data doesn't look at, there's not as big of a gap there, right? And so if we don't have the accurate data because we're not complete, and if we're not getting to the actual community, we can come away with some kind of inferences that then can lead us to harms. So that's where having reliable, standardized data is really important.
Awesome. Britt.
Thank you.
I'll take down my hand before I forget, because I would do that. So this was a great presentation, Dr. Chobolo. So thank you so much for this. A few of the observations / questions that I have is with the engagement in care and Medicaid for BIPOC families with children. Do you think that there is a correlation with their overrepresentation in being reported to CPS or having child protection engaged and having that family separation happening or that historical separation happening? And also noticing whether or not part of that lack of engagement in care is with BIPOC folks having their mental health and or substance use disorder criminalized. So they are likely facing more of a carceral response in the jails, or we've been noticing that there is a disparity with our civil commitments at the hospital. When you talked about the CHWs and the MNsure navigators and the doulas with getting the grants to pay for that's an awesome idea, especially like I'm a drug counselor and I work at Hennepin Healthcare and I work with the HIV clinic there. And the workforce for LADCs is well over 90% white folks. And the folks that we serve are definitely not that demographic. We work with a lot more BIPOC folks, especially in the urban areas. And there's been the desire and the discussion to find ways to make it less of a hassle and make it more realistic and affordable for us to diversify our own workforce. And then the final kind of question was more just kind of like figuring out where that cutoff point is for people who are on Medicaid and or Medicare. At some point during incarceration, they do lose it. And I'm just wondering if that's something that happens when they go into like a 1+ year setting, or is this a matter of months? Because I think that they keep it in the downtown jail because they are able to get started on like on Suboxone and get their methadone continued there. But I'm not sure if that carries over also to the workhouse, and I know it doesn't carry over to the DOC.
Yeah, so that is the distinction. It's federally right now an inmate exclusion. So if you're 12 months or longer, then you federally the federal government won't match funds, right? And so one of the Medicaid financing, for folks is that for most things, the federal government will pay a certain percent, whether it's 50% or sometimes 70% or higher of the care, and the state has to pay the other 50 or 30%, right? And so, so that really dictates a lot of what the state decides to do, because they want to do things where they'll get a good federal match. And so there's nothing prohibiting Minnesota from doing it that I'm aware of at this point, but there is a federal, exclusion where they won't, and so then our policy says we won't over a year. To your first question, so we were actually trying to talk more about like a lack of engagement from our standpoint and wanting to improve that. But what you're talking about and observing has been seen. In fact, Dr. Rachel Hardiman at the U of M has kind of shown how women who've witnessed police violence, right, are less likely to go get prenatal care. And so we think of things in all these silos, but people think about institutions and how they've been treated, right? And so if you've been treated poorly in the school, and you've been treated poorly by the police, and you've been treated poorly when you go to apply for social services, then you're not going to want to go to the doctor either, because it's all connected, right? Yeah. And so we definitely recognize that that's a piece of it, and how when we do community engagement, we're really hoping to be intentional. In fact, we cited the Cultural Wellness Center's Year of Learning, where they not only have folks engaged and do things like meals and childcare and support and paying them for their time, but they actually have navigators there to help people. So when you're talking about your experiences on Medicaid and you bring up that you might be kicked out of your house, because of an issue with your landlord, they have someone there that can help you navigate the services you need to kind of help, with that issue as well. And that's the type of community engagement we hope to be able to, fund and that type of relationship, so that you really come to here to kind of share, and, you're learning, we're learning, it's kind of bi-directional, right? And then the second or third one was about, I think, workforce. I forgot.
Yeah, you were mentioning like the $200 help pay for being on like the doula registry, and like for the CHWs getting them certified. And it's definitely, I was just giving a comment about that being a great policy and idea, because my own workforce definitely needs to get a heck of a lot more diversified itself. I think last I heard, the LADCs in Minnesota are 92% white.
Well, thank you, Nathan, and thank you to the committee for this incredible engagement. I think this is kind of the Public Health Advisory Committee version of gushing, I'm pretty sure. Gushing with gratitude.
Absolutely.
We are very, very grateful. In the interest of time, I am going to move forward with 3 questions to the committee. We may not get to all 3, but Nathan, this is a public setting. This is recorded. And so in your work with community outreach, this is a community committee. And so you can feel free to take back whatever insights that we glean from these questions. But you are off the hook now. You are off the clock. You can feel free to sit back and relax, loosen that bow tie a little bit if you want to, you know.
Thank you. Thank you. Yeah, I look forward to hearing. I'll be taking some notes.
Wonderful. Thank you. Okay, so those 3 questions again, and I am keeping an eye on the clock. So we may have to consolidate those last 2 or something because we do still have to hear a report from the interim commissioner. And then there's news, big news to share that we'll also need to discuss. Those 3 questions were: 1, what was your gut level reaction to this presentation? So this is a good time for commentary, especially if you can keep it down to 1 or 2 words. What new insight did you get from this presentation? And you can share as you feel moved, but let's just in the interest of time.
1 or 2 words. 1 or 2
1
words.
or 2 words. This one said 1 or 2 sentences, but 1 or 2
Oh, I'm
words
sorry.
would probably be better. That's
Yeah,
okay.
that was the insight one.
Yes. And then the third is, does this report resonate with any of the committee's priorities? Is there an action for the committee, or does this report inform our work? And then you're allowed to elaborate a little bit on the question number 3, if you're able to. So I will go first with gut level response, and then Alicia, then Angeli, and then Anna. And you know, my gut level is, whoo, it was simultaneously a lot of data, but something I know the committee has been hungry for. Certainly a report, a well-delivered, well-executed report that delivered a lot of that news. But we have a really great place to start in my mind. That was, do not follow my example, 1 or 2 words for this one.
You don't get to answer the second question. No, I'm kidding. I'm kidding.
Alicia, then Angeli.
Hi, everyone. So my first 1 or 2 words were, unfortunately, duh was the first word that like kept coming up. I was like, I know this, duh. I know this, duh. I've seen this, duh. And strive was the other word that came up, is that I think that people try really hard to be as well as they can be, and life gets in the way, and systemic barriers get in the way. And sometimes it's really, really hard to see those systemic barriers because they feel invisible to some people, right? They seem invisible. But the fact that people have tried really hard to do well, and that there's work being done, people are striving to do well, and there's still, you know, so much to be done. I think that that's what stuck out to me. So duh and strive, which is kind of an odd pairing, but that's what happened. And then I think that there's a lot of relevancy here to the sub committee that I'm on, and I will be aware of the time we have left, and I will yield to the next person.
Awesome. Yeah, I do think gut level reaction and insights kind of do go well together. And, you know, good luck to the chair that tries to keep you from sharing too much on this one. So it'll be Angeli, Anna, and then Britt.
Yes, I'll say urgency, and action oriented. Oh no, accountability. That's the word I wanted to choose. I love the accountability call outs, and our subcommittee is thinking about, you know, how to structure our recommendations to city council. And I think we got several ideas from this presentation, and just that making that sense of urgency about these issues apparent, and what is the action going to be at the end of the day? How are we accountable to that? So I'll pause there and we can go to the next person.
Okay. Anna, Britt, and then Aaron.
My word is impressed with the presentation. As someone who works on health disparities in commercial tobacco use, thinking a lot about this data in my own work, and impressed with the way you were able to disaggregate some data that's often clumped together, like on US versus foreign-born Black residents. Also, as someone who works on a government program at MDH, impressed with the way you're looking at changing processes, which I know can be really difficult with these programs, especially those that are really ingrained. And so I like to see some of your recommendations around improvement. And yes, very relevant. I'm also on the public health, racism as a public health crisis subcommittee with the previous 2 committee members who spoke, and we will be talking about your presentation in our subcommittee.
At length, I would suppose.
Yes, so thank you.
Britt, and then Aaron, and then Lisa.
All right. I had the similar gut reaction of the ugh, duh. And the new insights, where I was taking notes actually too. I was not aware of the immigrant bias, or the healthy immigrant bias. Because I know that a lot of folks who are coming in from other countries, especially if they're non-white, definitely have their own barriers with our systems. But I was not aware that there was the healthy immigrant bias, but it's not surprising either. It just kind of confirms like the things that I see when I'm in my patients' charts and seeing like there's definitely a heavier representation of BIPOC folks who get diagnosed with malingering and not having their physical issues or mental health crises taken seriously. And of course, I believe this resonates with PHAC priorities. I think that just last month we were talking about Dr. Chobolo and listening to some of the observations noticed with Medicaid and health injustice, because access to care is a huge part of, like, I think we're food, drink, medicine, which really needs to be renamed still. But
thank you, Brett. Aaron, Lisa, and then Meredith.
Yeah, my word would be actionable, and as my prior comments indicated, I think we all certainly on this panel and this board agree with you, and the trick is how to get it through the sausage making of the legislative process, and I think you've made wonderful suggestions there, and wish you the best of luck, and let us know how to support you.
Thank you. Lisa, Meredith, and then Margaret and Commissioner Ritchie, I'm going to have you go last. So go ahead, Lisa.
Or even not at all.
Okay.
I'm going to go in the doom and gloom category here with hurdles and barriers to access. That was a gut reaction to me. Just sort of what one has to overcome to access the system was my gut reaction. And my new insight, I'll echo what Bert said. The healthy immigrant, I thought that was kind of fascinating. And he sort of said maybe it is self-selection, maybe it is these hurdles and barriers are a combination thereof. But I thought that was insightful. Thank you.
Thank you. Meredith, Terry Ann, and then Twee.
Yeah. For my gut reaction, I think it was just, we've seen the data before, but it was grounding to see it again and to see it so clearly broken out and disaggregated. And so what I appreciated about the presentation is really using data-driven information, but then following that thread all the way through to here's how we, engage the community, and here's what our call to action and what our recommendations are. So it was really nice just to have that whole kind of piece laid out for us. So it makes it very, very palatable to think about how we can have a role in this work. So I appreciated that. And then just an insight was really looking at the quality and the access levers and just thinking about the nuances there. I guess I had not thought about all of those things where, like, even if we're implementing policies and the state has implemented policies to try to improve outcomes and reduce disparities and promote racial and health equity, but even with those policies in place, there are still things like, even if you have access to employer insurance, it may not be affordable. Or is the care, like, how are we defining quality of care? And what does that mean to BIPOC communities? And are we really looking at the things that matter to communities in terms of quality? So just realizing that there's so much more work to be done there.
Thank you. Harry Ann and then Twee.
Hi, sorry everybody that I was a few minutes late to the meeting tonight. This was, I just agree with what everybody else said. It's just, it's like on the one hand, you feel like you know this already, but then to see that data is really helpful. And I think, even just as we talk to our neighbors and people in our community who aren't on this board, we know we are in a better state in terms of access, and yet look at all the barriers that are here. And just this assumption that just because something is available, why don't people take advantage of it, right? Because it's just super complicated. And then that whole, being able to stay on it and keeping people retained so they can build relationships with providers. I know all that, but to see, like you said, Meredith, this disaggregated data and to really just kind of look at all these pieces, it does make it feel like even more urgent that, like, let's do something now while we have this budget surplus. Like, let's not do these things like just giving it back and cutting taxes. Like, let's do something now.
Okay, well, this is the City of Minneapolis Public Health Advisory Committee, so we are not able to recommend to the legislature on how they spend those billions.
I know, but we can have
but
conversations.
You feel free to
our
talk to your
circles of influence.
representative to ask your council person to lobby appropriately. Twee.
Yeah, so my two words are valuable and framework. I guess they go together. So valuable framework. I think that it really provides a really good framework for how we can examine the barriers that need to be navigated, not only, between racial categories or groups, but even within. As an immigrant myself, I can attest to being lumped into that Asian monolith kind of category, and realizing that even within, that category, there are needs that are there and need to be addressed that aren't, just being glazed over. So I really appreciated that aspect.
Wonderful, great insights, committee members. We have about 26 minutes left, and so instead of going through and asking you each one by one on the third question, I'm going to pose the third question to the entire committee. Then I'm going to give you the chance to raise your hand. We will hear from at least 3 people, or else I will call on you. I'll do it. I'm in Orlando and I'm on this meeting, so if I'm going to participate, so is everybody else. The final question is, does this relate to PHAC's priorities? We know that it does, but is there an action for the committee, or does this report inform our work? And if you're thinking of an action, what is that action? And if informational to our priorities, how so? And the bit of information that seems to be really sticking with me, I'm happy to go first, is the chart that showed the disparity related to asthma. And, we are not just, we received an excellent presentation. The presentation and report is related to Medicaid, but we are not confined by assisting in the remediation of this disparity by addressing issues related to Medicaid. This could be an issue similar to lead ingestion, where, maybe all the kids in a particular zip code have the same old carpet that they've had from who knows how long. And so if we're able to identify and kind of break apart a good question, like identify a good question, see if there's a possible solution there, then I would love to use that data to do so. Brett, your hand is up. That will be number 1 of 3.
And I even answered a little bit the last time, but
You're great.
Potential action item that seems feasible for the city of Minneapolis. So like there was through the state of Minnesota, that program that was helping people get into like healthcare assistant or nursing assistant school and like make sure that like it was paid for, they had grants to cover it just to get people into the workforce. What if the city was able to notice some of the care disparities, like with therapists, counselors, community health workers, navigators, and find some like CARES Act money or other grants to assist with paying for tuition or licensure, obtaining licensure, getting licensure renewed, or CEUs that might be needed for whichever, just to help us have a workforce that is more representative of the people that we serve.
Thank you, Brett. Okay, I'm not seeing a hand, so I'm just gonna zoop up and down on my list. Oh, and I'm right at the bottom. Twee, you get to weigh in one more time. Did any potential actions come to your mind, or did this presentation inform any of the work you've been doing on our priorities thus far? You can feel free to rehash anything you've already said. That's fine.
I was just gonna say I kind of let it all out there the first time. But I will say that it definitely does fit into what we're doing. I think that it's really important to address these inequities, and I think it's part of why we're here and in public health. So I'll just leave it at that and let other people take it from there.
Wonderful. I get the feeling that the committee has expressed everything that it would like to express, but I will give you to a mental count of 5 on my part to put your hand up if you have any final thoughts. Oh, it's Margaret.
I was just gonna say kudos to Britt, because that is exactly what the mental health environment and mental health subcommittee has talked about, is about the difficulty of increasing a mental health workforce because of the strict kind of licensure rules of who can and who cannot, be a therapist. So
it's expensive
you perfectly summarized everything that the subcommittee had talked about, and really felt like that was an actionable item,
And
so thank you.
Here's why I think it's an actionable item, because a few years ago when I was on the Merrill task force around opioids, the name of it was escaping me, it was a really long name. That was one of the items that we had on our list of recommendations from the entire task force, is finding funding for being able to diversify our workforce and have more culturally relevant care provided by people who share culture.
Thank you. Thank you. Wonderful. And then Meredith, your hand's up.
Yeah, I just wanted to build on what Margaret was just saying. For Hennepin County, we're actually using some of our COVID response funding to focus on building mental health, building capacity among mental health providers, and also, being able to provide more culturally focused care, mental health care in Hennepin County. So if that is something that the city of Minneapolis decides to take on, is it perhaps something where if we're already working in that space in other areas within the county, and it seems to be like a pretty large effort, is that something that we could build or partner on as well with Minneapolis? Just because I think there's already some momentum and some resources that could be put into that. So.
Yeah, definitely that could be in the mix. You know, and that's another thing that the subcommittee talked about, is that it's sort of like we have this impression within the city that like mental health belongs over there, you know, in the county services, and, you know, that is detrimental, you know, to the city of Minneapolis.
Well, and there are many community providers that are not,
Right.
you know, connected to the county where it's important. And it doesn't have to be a licensed therapist either. There are other ways to support mental well-being and provide mental health services. So
yes, absolutely. Thank you.
I think a great resource for learning about resources and ways to build on this would be looking at Minnesota Care Partner, because they do prioritize hiring BIPOC practitioners, therapists, arms workers, child therapy workers. And I think they also have a partnership with Hennepin CPS as a diversion program, and they can provide, like, for free to the clients, BIPOC folks who are doulas, parenting coaches, and all that.
Thank you, everyone, for your fantastic insights. Per usual, you sound like some of you are almost ready to break into subcommittees and get back to work, which I love. We do have other items on the agenda to get to before 8 o'clock, some of which could be longer than others, but I will do my best to get us all out right at 8 on the dot. Interim Commissioner Ritchie, if you are available, now would be a great time for your report.
Wonderful. Oh my gosh, this discussion has been amazing, and I'm so happy to have been a part of it. And I have so many thoughts. I've been emailing Margaret and thinking about how Louisa can come and present on data, and how Pal can come and talk about health equity, about how we should really think about then refreshing those opioid recommendations, because the environment has changed. I mean, we're 4 years into it and things are different. And so really kind of looking at what we can do to make sure that we're being adaptable, flexible, resilient to the changing times. That being said, we do have a lot of new kind of transitions in our staff, and it's really exciting. And so I wanted to share some of those with you. So we have new staff members. We have the assistant school-based clinic manager, Polly Yang, and she started, I believe, a week ago from Monday. Cecilia Hardacker, mental health counselor in the school-based clinics, and then Teresa Hogan, immunization and vaccine coordinator. We have some pretty kind of, you know, monumental staff transitions. We have Josh Schaefer, who's been promoted to the Director of Operations and Business Improvement, and then Luisa Pessoa Brandau, who I mentioned earlier, promoted to the Director of Public Health Initiatives. They're taking on the body of work that Noya Woodrich, our former Deputy Commissioner, leaves behind as she goes to the Department of Health for the state and is the Director of the Maternal and Child Health Division. So we're, you know, happy for her, thrilled for her. We're also super thrilled that Josh and Louisa are able to step up. And so we're looking forward to them leading in those spaces. We also have Tiana Cervantes, a senior public health specialist in maternal child health. She was previously in the environmental programs area as an inspector, and then Marcia Anderson promoted to a project coordinator. Also, Stephanie Graves has been promoted to the manager of maternal child health. So those are some staff updates.
Wow.
Yeah, a lot, right? So let's see. Government structure. Actually, I'd really just like to skip over that and we can come back to that. The mayor made a presentation today at Committee of the Whole, and I can share that in a link with you all, but I don't really have any more insight to that other than what the mayor and the council talked about during that meeting. So I'll share that link with you. But what I really would like to do in the next few minutes is turn to Margaret and have Margaret kind of give us a recap of the Public Health Heroes event that we celebrated for National Public Health Week. I think it was a couple of weeks ago. So Margaret.
Margaret, I'm going to need you to unmute.
Yep, I'm just trying to get my correct screen up.
Oh,
So
sure.
hang on here 1 second. Hold on. Let me try again. Come on. It's here. I can see it. I just can't find it on the share button. So hang on here 1 second. And it's a pretty short presentation. Oh, there it is. And let me know if you can see it.
Yes.
Perfect. Okay. So we had Public Health Week from April 11th to the 15th. And the theme of the week was Public Health is Where You Are. During that week, we had several activities that were suggested. These are publicized on the intranet within the city enterprise. I know I shared the flyer with all of you and with our community mental well-being team from the CHIP initiative with Hennepin County and Bloomington, Edina, Richfield. And so this just gives you an idea of some of the activities that we suggested. Monday, April 11th actually was the theme of racism as a public health emergency. And so we had suggested some resources for people to be able to just watch and learn and increase their own understanding on how that impacts people within our community. We had a week-long activity about taking a 15-minute walk. And then while you were taking that walk, to ask yourself some questions like, what was the weather like? What neighborhood or environmental changes did you notice as you walked? Did you see others out walking? And will you walk the same route tomorrow? Just as a way of getting people to be thinking about public health and public health being wherever it is that they are. On Thursday, we celebrated our local public health heroes. And so there were 6 people that were named in different goal categories. So first up was Craig Hedberg for Safe Places to Eat, Swim, and Stay. And then the Cultural Wellness Center earned a Healthy Living Award. And Eureka Recycling earned the first Pam Blixt Memorial Award. And for those of you who don't know who Pam Blixt is, emergency preparedness as a thing really did not exist until I think the early 2000s. And the city of Minneapolis had received some grant money to be able to put together an emergency preparedness department work unit, which we had never had before. And Pam Blixt was the first and really the only emergency preparedness manager who literally built the emergency preparedness program from nothing. So when she passed away last year, we wanted to really embed an honor to her in this particular goal area. And so this was the first time that she was named in this particular goal of a strong urban public health infrastructure, and Eureka Recycling was the award winner there. Khadija Cooper from the Annex Teen Clinic and her work with a Young Adult Advisory Council won in Thriving Youth and Young Adults. And in memoriam of Mark Jonigan, he won an award for thriving youth and young adults and violence prevention. He was the CEO and founder of Twin Cities Recovery Project, which works primarily with grief and trauma and recovery for people that are that have substance use, but also are victims of violence. And he was tragically killed in a car accident in last December. And then the last award was given to Barb Harris from the Minneapolis High Rise Representative Council. I wanted to just share a picture of the artist, Marlena Miles, who is a local artist, a Native woman. We contacted her and she created a unique design for the local Public Health Hero Awards. And she happened to come on the day of our celebration to to deliver the awards to us. And then I had a chance to meet her and snapped this photo. So I was just so pleased to have a chance to see her and meet her and thank her for the beauty and the uniqueness of the art that she brought. She actually has art on display in the new public service building. She has 6 large panels on the skyway level, and then there's also artwork in a 6th floor conference room. Here is a picture of our own Craig Hedberg, and Heidi was the MC of the day, and Cindy Weckworth is the other person in this photo, and she is the director of food, lodging, and pools. Then Sister Peace from the Cultural Wellness Center received her award. And again, Heidi was the MC throughout, so you'll see her in every picture. And Patty Bowler presented the award to Sister Peace and the Cultural Wellness Center. And Patty oversees school-based clinics, healthy living work, and policy initiatives. Here's the picture of the folks from Eureka Recycling. Again, Heidi's in the picture, and the 2 folks that are on the right are health department staff. The woman with the rainbow colored scarf is Tony Hauser, the current emergency preparedness manager. She worked under Pam Blixt, so it was quite fitting that she gave this award. And then Justo Garcia, who was one of the people who helped nominate Eureka Recycling. Here's Khadija Cooper holding the award, and in the middle is Sarah Sheely, who works in the health department on sexual health. She also works on some collaborations. She does a bunch of things, but her primary role is with sexual health, and so she was excited to be able to present the award to Khadija. This is the group from Twin Cities Recovery Project that came in support of and honor of Mark Jonigan. The person holding the award is George Lewis, the former CEO of Twin Cities Recovery Project, who worked tirelessly and closely with Mark Jonigan. This is the group of with Barb Harris and Minneapolis High Rise Representative Council. There are several health department staff in this particular photo, but Barb is the one who is holding the award, and some of the other council members are there with her. And then, of course, I couldn't pass up an opportunity to take some pictures of our staff because we had a resource fair that day. So it's always fun to be able to highlight the people who are literally the boots on the ground doing the work and showcase some of their work to the public. It was really a celebratory day. You can see the smiles on so many people's faces. I think everyone was just honored to be there, to have an opportunity to have an in-person event. You can see the white chairs that were set up, and the presentations were given in front of the Father of Waters statue. Here's a couple of other folks. I love that picture of Jose in the bottom left with the Father of Waters giving his own presentation. And then we all had a chance to meet Pau, who is standing in the photo looking at the beverage, Rethink Your Drink with the blue mask on. And so we'll have to have Pau at a future meeting again. And that's the end.
Awesome. Thank you for that celebratory moment, Margaret. Thank you for
Yeah,
taking
it's nice
this photo.
it's nice to celebrate.
Indeed, indeed. Now we have 3 minutes left. Was there any additional reporting from the interim commissioner? Don't believe so. I think you turned your camera off, which is like the universal sign for that's all I have. Last on the agenda, we have reports from the subcommittees. I know that the Racism as a Public Health Subcommittee met yesterday. And so I would love just to hear 1.5 minutes to 2 minutes of how that went and any insights that you have. And then if any of the other 2 committees have a report, we'll hear it. If not, we will adjourn. And Julie, and the universal sign, if I have something to say, you are unmuted and your camera is on, so go for it.
Yes, I volunteered to report for my subcommittee. So yesterday we had a very productive meeting, and we discussed our approach that we'd like to take. Similar to the spirit of the presentation today, we are looking to be more actionable, and racism as a public health crisis is such a broad topic. What we've decided to do is to select a topic and create a case study that demonstrates where certain disparities lie that are rooted in racism, and present a multifaceted approach to the City Council of how we can address this issue. So some ideas that we were talking about were Black maternal health. And then today we also wanted to ask the subcommittee if anybody here has any ideas for what might be a good topic to build our case study around. And one piece I forgot to mention I wanted to is that in the case study, we're going to identify where we might have gaps in the data and where we need to fill those in, such as our presenter today talked about the importance of disaggregated data. So that could be a potential example there. So yeah, does anybody have any topics that you think that would be a good place to build our case study around?
And don't worry if you don't have any immediately, because we can follow up by email, giving everyone just a chance to think about the question, to noodle on it. Maybe in the morning, have some coffee, think about case studies. Okay, I'm not seeing any hands, but let's do follow this meeting maybe tomorrow with a committee-wide email requesting feedback on the case studies. Were there any reports from our other 2 subcommittees? I don't believe that any met. Okay, not seeing any. Whew. You continue to make me proud. Public Health Advisory Committee for the City of Minneapolis. Really well done today. There was a lot to chew on. I know you're going to be taking a lot back with you. Great engagement, great insights, great contributions. Well done. Well done.
Jerome, can I just say thank you for bringing him in as a speaker? Like, I think you were the one who made that connection, and I really appreciate that you reached out and did that, because I think that was really helpful for the group. Yeah, I just found it to be a really good presentation. So thanks for doing that.
Yeah, no problem. Could you imagine if I didn't? That'd be so funny. No, he's too good. He's too good. Well done, everyone. We are adjourned.
Awesome. Great
Yes.
meeting. Great to